Welcome to the Deep Dive. Today we're tackling something most of us hear about, maybe even track, but don't always grasp. Blood pressure. You know that phrase, 120 over 80, seems simple, right? But behind those numbers, well, it's this really intricate, constant dance between your heart, your arteries, even your brain.
Absolutely. And if you just think of it as like a static number on a machine, you miss so much. You miss the incredible physiology working nonstop. So our mission today in this deep dive is to really get into the source material. We want to understand the mechanics, what the heart's actually doing, decode the numbers, which can be surprisingly confusing, and look at how it's all regulated and maybe touch on why getting a truly accurate reading is, well, trickier than you'd think.
Okay, let's start right there, the basics. What are we measuring exactly when we say blood pressure?
Good question. Fundamentally, it's the systemic arterial pressure. It's the force the blood pushes against the artery walls as it circulates. Some sources call it arterial tension because the blood is literally putting tension on those walls with every single beat. And the engine driving it all, of course, is the heart, a pretty amazing pump contracting, 50 to 80 times a minute, even when you're just sitting there?
Right, and those contractions, that cycle, the sources mentioned, you can actually hear it, right? Two sounds with silence between. That gives us our numbers.
Exactly. The cardiac cycle has two main phases. First is the contraction, the powerful squeeze. That's called systole. It's when the ventricles pump blood out. The right one sends it to the lungs. The left one shoots it out through the aorta to the whole body. That big push corresponds to the maximal pressure. That's your first number, the higher one. PAS, we call it.
Okay, PAS, maximum pressure. Got it. And the second number, the lower one.
That comes during diastole. That's the relaxation phase, you could say. It's the time between beats when the heart muscle chills out, the ventricles refill with blood, and that corresponds to the minimal pressure in the arteries.
PA.
Now, here's something I found really interesting. We focus so much on the heart as the pump, but the arteries themselves, they're not just passive pipes, are they?
Oh, absolutely not. That's a huge physiological point.
Yeah.
Arteries are living tissues. They're elastic. They have muscle. So during systole, when that wave of blood hits, they actually stretch. They dilate to absorb the pressure. But then, during diastole, while the heart is refilling, the artery wall actively springs back. It recoils. And that recoil, it helps push the blood along. It keeps the flow going in a sort of pulse all through the body.
Wow, so the arteries are kind of like secondary pumps, helping out between heartbeats.
Precisely. It's crucial for maintaining that continuous flow, making sure blood gets everywhere, scalp to toes, even during that brief pause when the heart's refilling. Okay, let's shift to the numbers themselves, because this drives me crazy, and I bet it confuses listeners too. Why 12 over 8 when the machine says 120 over 80?
Yeah, it's purely down to units. It causes so much unnecessary confusion. Officially, the international unit is the Pascal, Pa, but historically and still clinically, we measure it based on how high it pushed a column of mercury. So we use millimeters of mercury, mmHg, or sometimes centimeters, cmHg.
Ah, so 12 over 8 is...
It's just 12 centimeters of mercury over 8 centimeters of mercury, which is exactly the same pressure as 120 millimeters over 80 millimeters. Just different scales for the same thing. Silly, but that's how it is.
Okay, that clears it up. Now, beyond those two numbers, clinicians sometimes use a single value, right? Like mean arterial pressure? What's that about?
Right. So while you might focus on the 1280, doctors often need a sense of the average pressure driving blood into your tissues over the whole cycle. That's the mean arterial pressure, or MAP. It's not just a simple average, though. Because the heart spends about twice as long relaxing in diastole as it does contracting, in systole, the calculation weights the diastolic pressure more heavily. Roughly, it's like systolic plus 2 times diastolic divided by 3.
I see. So it gives a better picture of overall perfusion, the blood flow getting to the organs.
Exactly. And there's another single number they look at, pulse pressure. That's just the difference between the top and bottom number, systolic minus diastolic, and that gap matters. A really wide pulse pressure can indicate stiff arteries, which is a big cardiovascular risk factor, even if the 120 and 80 seem okay on their own.
Okay, ranges. Let's talk pathology. When does it become high blood pressure hypertension, and why do the goalposts seem to shift sometimes?
Generally, yeah. Hypertension is defined as consistently measuring above 140 systolic or 90 diastolic, so 130, 90 mmHg. But you're right, the guidelines can vary, especially for people with other health risks like diabetes. Some guidelines, like the US ones from 2017, might actually aim for lower targets, maybe even 1380 in certain situations. The trend really is towards recognizing damage happens even at lower pressures over time, so the definition of optimal keeps getting refined.
And what about those weird situations, like pressure being high only at the doctor's office?
Ah, yes, several important variations. The classic one is the white coat effect. Just being nervous in a clinical setting makes your pressure shoot up temporarily. False alarm sometimes. Then there's the opposite, masked hypertension, where it looks fine in the clinic, but it's actually high when you're going about your day. That's trickier to catch. We also watch for pinch tension, where the systolic and diastolic are really close together, less than 40 millimilli HG apart. That can signal other issues, maybe with how the heart or vessels are functioning.
Which brings us neatly to regulation. This number isn't fixed, is it? It's changing minute by minute. How does the body manage that, keep it stable-ish?
Oh, it's incredibly dynamic. And the regulation is super complex. You've got flow, resistance, blood thickness, all playing a part. But basically, there are two major control systems. First, you have the nervous system for rapid second-to-second adjustments. Think of the vagus nerve, for example. It can instantly slow your heart rate and relax blood vessels if pressure gets too high. It's like the body's quick response team.
Okay, so nerves handle the sudden stuff like jumping up quickly or getting stressed.
Yeah.
What about longer-term adjustments? Hydration levels, things like that.
That falls more to the humoral system. This uses chemicals, hormones, peptides circulating in the blood. Some act fast, like adrenaline and noradrenaline from your adrenal glands. You know, the fight or flight hormones. They rev up the heart, tighten vessels, boost pressure quickly.
But there's that other, more complex chemical loop too, right? The one targeted by blood pressure meds.
Exactly. That's the big one for long-term control. The renin-angiotensin-aldosterone system, or RAAS. It's a whole cascade involving the kidneys, liver, lungs. Essentially, your kidneys sense blood flow. If it's low, they release renin. That triggers a chain reaction leading to angiotensin production, which powerfully constricts blood vessels. And it also makes your body hold on to salt and water via aldosterone. Both actions crank up the pressure and blood volume.
So the system designed to stop you collapsing from dehydration is the same one that, if it's overactive, causes chronic high blood pressure.
You got it. That's the double-edged sword. And understanding that RAS cascade is precisely why many common medications like ACE inhibitors or ARBs work. They interrupt that chemical chain reaction. It's this whole balance. Why effort or stress raises pressure and why just resting brings it down.
Given all that sensitivity, how do we mess up the measurement itself, aside from the white coat nerves? Physical things.
Crucial point, especially if you're monitoring at home. Yes, beyond anxiety, simple mechanics matter hugely. For a good reading, you need to be properly rested, sitting quietly, but also the cuff, the brassard around your arm, it has to be the right size. If it's too small for the arm circumference, it squeezes unevenly and artificially inflates the reading. We sometimes call that the gross bras or thick arm effect.
Okay.
Also, pressure isn't always identical in both arms. It's often slightly higher in your dominant arm, so ideally you check both initially.
Let's rewind a bit. The history. How do we even start measuring this? It seems hard to access.
Well, the very first attempts were pretty invasive. Back in 1828, Poiseuille used a mercury-filled U-tube, a manometer, stuck directly into an animal's artery. He called it an hemodynamo-meter, and right away he noticed something fascinating. The pressure fluctuated with breathing. It went up slightly on exhalation, down on inhalation.
Wow. So even just breathing affects the reading. Nearly 200 years ago he saw that.
Yep. Shows how responsive the system is. But the first non-invasive device, the kind we'd recognize, came much later from Scipione Rivaracci in 1896. Still, the gold standard method used today, the reference method, combines that inflatable cuff on the upper arm with the stethoscope, the auscultatory method.
Right, the listening method. Can you walk us through that? What are they listening for?
Sure. The examiner inflates the cuff way above your expected systolic pressure, so it completely blocks blood flow in the brachial artery. Then, they slowly release the pressure. As the cuff pressure drops just below your systolic pressure, blood starts spurting through the partially opened artery. That turbulent spurting flow creates sounds tapping or humping noises. Those are the famous Korotkov sounds.
And the first sound they hear is...
That very first appearance of the Korotkov sound marks the systolic pressure. It's the peak pressure overcoming the cuff's squeeze. The sounds continue as the cuff deflates further. But eventually, when the cuff pressure drops below your diastolic pressure, the artery is fully open again. The blood flow becomes smooth, laminar, non-turbulent, and the sounds disappear. That moment of disappearance, that's your diastolic pressure.
Okay, so if a listener goes for a checkup, what's the ideal way it should be done to minimize errors?
Right, the protocol matters. You should be seated comfortably, maybe half sitting, arms relaxed by your side, and importantly, rested for at least 5, maybe 10 minutes beforehand. Crucially, the arm being measured needs to be supported at about the level of your heart. If your arm is hanging down low, gravity alone will make the reading artificially high.
Ah, okay.
And as I mentioned, check both arms the first time. Use the higher reading as the reference. Often they'll measure at the start and end of the visit too, just to see if there's a white coat effect happening.
Now, fast forward to today. Those automatic machines are everywhere. Pharmacies, home use. How do they work without someone listening? Are they using mercury?
No, mercury's mostly phased out due to safety concerns. These electronic devices generally use what's called the oscillometric method. They don't listen for sounds. Instead, the cuff inflates and deflates automatically, and sensors inside detect the vibrations, the oscillations of the artery wall as the blood flow changes. The machine's algorithm analyzes the pattern of these oscillations to estimate the systolic and diastolic pressures. It's convenient, repeatable.
And that automation allows for things like wearing a monitor for a whole day.
Exactly. That's ambulatory blood pressure monitoring, ABPM, or sometimes called MAPA in other regions. You wear a cuff that automatically inflates and records readings every 15-30 minutes over 24 hours. It's incredibly valuable because it captures your pressure during normal activities, even during sleep. It eliminates the white coat effect and can catch that masked hypertension we talked about. Gives a much better picture of your average load.
Okay, contrast that high-tech approach with, say, an emergency situation. No fancy machine available. How do paramedics or ER docs get a rough idea quickly?
Well, in intensive care, the absolute gold standard is invasive monitoring. A tiny catheter right inside an artery, giving a continuous beat-to-beat pressure waveform, super precise. But out in the field or in a chaotic ER, we often rely on palpation, just feeling for the pulse.
What can feeling a pulse tell you about the actual number?
It's a rough guide. We check central pulses like the carotid in the neck or femoral in the groin, and peripheral ones like the radial at the wrist or pedal on the foot. A common rule of thumb is if you can feel a radial pulse, the systolic pressure is probably at least 80 millimolars Hg. If you can't feel it, that suggests the pressure might be weak or sleep low. But it's not foolproof. Things like cold or vessel disease can make pulses hard to feel even if pressure isn't critically low. There's also capillary refill time. Pressing on a fingernail and seeing how quickly the pink color returns. Less than 2 seconds is normal. It's very quick, but also pretty unreliable, honestly. Needs careful interpretation.
And finally, consumer tech seems to be going wild now. Beyond the arm cuff, what other strange or novel ways are people trying to measure this?
Oh, it's evolving fast. You see devices claiming to measure accurately at the wrist or even the finger. These aren't the reference standard like the upper arm, but they're getting better. What's really intriguing, though, is the move towards sensor fusion and passive monitoring. There are smartphone apps being developed that use the camera for something called transdermal optical imaging, basically analyzing tiny color changes in your face caused by blood flow to estimate pressure changes.
Seriously, just by looking at your face.
Sounds like sci-fi, I know. And other phone apps try to use the flashlight and camera sensor pressed against your finger, mimicking oscillometry. Accuracy is still debated, but the tech is pushing forward. And then there's the integration into everyday objects. For real passive monitoring, some companies are building sensors into, well, toilet seats.
You're kidding.
Nope. The idea is you sit down, it discreetly measures heart rate, maybe estimates pressure via ballistocardiography or other means, and tracks it over time without you doing anything. Still early days, but it shows where things might be heading.
Wow. Okay, so from Poiseuille, sticking tubes in arteries 200 years ago, realizing breathing changes pressure, all the way to potentially getting readings from a toilet seat. What's the big takeaway here?
I think the biggest takeaway is just how dynamic blood pressure is. It's not one fixed number. It's constantly adjusted by your nerves, by complex chemicals like the RAAS system. And it's incredibly sensitive to everything, your stress levels, whether you just walked upstairs, even if the cuff fits right.
So for listeners, understanding that complexity, knowing about artifacts like the white coat effect or needing the right cuff size, or even just arm position, that's key to making sense of your own readings, right?
Absolutely. Interpreting the numbers requires knowing a bit about the physiology and the potential pitfalls of measurement. It's not just about the number itself, but the context around it.
And thinking back to Poiseuille,
Yeah, nearly 2 centuries ago.
he found that just breathing in and out changes our pressure. It's something that simple and unconscious affects it. It makes you wonder, doesn't it? What other tiny subconscious things might your body be doing right now, even sitting perfectly still, that could be subtly altering your blood pressure reading? Something to ponder until our next deep dive.